So my slide is visible?
Yes, sir.
Okay. Anybody wish to say anything? Otherwise, we'll be starting. Okay. So spine fracture. And before we going into the spine fracture, I'll be talking a little bit about the what I'll be covering. These are the references. So from where this my slides has been prepared. And what we'll discuss a little bit of anatomy and physiology of bone. This is very, very important. So this part I'll be covering. Again, some of these things will be repeated by Dr. Shruti in the osteoporosis class. And then very quick about the classification of the spine fracture and the treatment outline. So this what we'll be covering today. So this is the my background I have taken as a unit of the bone. So what is important here that there are in the bone there are three types of cells are there. Sorry. Okay, so three types of bones: osteoblast, osteocytes, osteoclasts. So I'll be discussing about these three types of cells, and the unit of the bone is osteon. So this whole you can see in the background of my PPT is a osteon. It has a central canal where the blood vessels are going on and the nerves are going on. The canaliculi where the osteocytes are sitting. The matrix, the bone area, these are the matrix, and dendrites run through these small areas. Osteocytes is a very special cell who has the different dendrites who are basically sensing. So coming back to the different types of cells, number one is osteoblast. Osteoblast are on the surface of the bone, there will be osteoblast. An osteoblast is a new bone forming, matrix forming cell. So new bone is formed by the osteoblast. So it is all over, it is entrapped by the bone matrix. Once it is being entrapped by the bone matrix, it is converted into osteocyte. Okay, osteocyte is the most abundant bone cell there. Osteocytes apparently look inactive because it is neither forming the bone or not causing the resorption of the bone, but it is very, very important for maintaining the homeostasis. It is having the lots of sensors. As you know, that calcium is very, very important ion in the body. The everywhere there are calcium, not just bone. Bone is basically a bank of the calcium. So everywhere in enzymatic reactions, in the nerve conduction, the coagulation. So calcium is almost needed almost everywhere. If the calcium is not there, then what will happen? Patient is not going to live longer. Patient is going to die. If there is a elevated calcium, then also patient is going to die. So the maintenance of the serum calcium level by hook or by crook is very, very important. And that is sensed by osteocyte. So osteocyte is continuously sensing the calcium level. And different organs who are maintaining the homeostasis of the calcium, I'll be coming to that slide, and that is being by the senses are sending signal to these different organs. So this signaling, central signaling organ is your osteocytes. So lots of abundant osteocytes are there who are basically formed from the osteoblast once being entrapped, and that is your osteocyte. Osteoclasts are a different kind of cell. They are formed from the macrophages. Macrophages later on, I'll be coming to the slides, they are being converted into osteoclast, which causes the bone resorptions, so that the matrix, what is your basically is a bank of the calcium. From there, the calcium will be released by osteoclastic activity. So three basic type of cell you have to remember: osteoblast, who is forming bone; osteoclast, who is resorpting the bone, resorption of the bone; and osteocytes, who is sensing and maintaining the balance. And now this pathway is important. No? So these are the two schematic diagram I have taken from the website, and I have mentioned the site's name. So how macrophage is converted into your osteoclast. So macrophage, they are having on the surface, when they are getting matured, there are rank receptors are there on the surface. These rank receptors, what is the full form of the rank? Rank is your, no, I don't remember the rank full name. Rank is your receptor activator of nuclear factor kappa. That is your rank. RANK. Receptor activator of nuclear factor kappa B. That is your rank. And rank L is the ligand against it. So rank is on the surface and rank L is this one. This is the rank L. This is rank and this is rank L. So the rank is on the surface. These are the receptors. On the surface, when the macrophage is getting matured, then on the surface, these rank, the receptors, they appears. And when they are binded by the rank L, then the binding of this rank and rank L is very crucial to form it in the active osteoclast. So for macrophage to this here, the rank-rankel binding is very, very important. So rankel is one of the very important ligand, is a protein. So the peptides, that is very important, which is basically causing the active osteoclast. And there are several conditions. One of them is parathyroid, continuous parathyroid. I'll be coming to this point later on because parathyroid has a very dual role. It causes both osteoblastic activity as well as osteoclastic activity. So parathyroid, they causes the rankel formation, and then more rankel means more binding with the rank and rankel, so more osteoclastic activity. So more rankel you don't want. And osteoprotogerin are different. They causes that means osteoclastic activity means more activity means more osteoporosis. Osteoprotogerin is different. Osteoprotogerin is also formed by the osteocytes and they are neutralizing rankel. So if they are binding with the rankel, what will happen? Less rankel will be available for the binding with the rank. So osteoprotogerin prevents the osteoclastic activity. So rank and rankel binding, rankel activates the osteoclastic activity, whereas osteoprotogerin, OPG, that causes the opposite. It neutralizes the rankel. So rankel is very important. So rankel is more formed by continuous stimulations of the parathyroid hormone. Basically, parathyroid hormone is what? Parathyroid hormone's main function, I'll be coming to that point later on in subsequent slide. Main function of the parathyroid is to what? Is the stimulation, continuous stimulation, so that the blood calcium level is maintained nicely. Again, now this is very, very important slide. So here the osteocytes are there. No? Osteocyte, what is I told? Osteocyte is very, very important to sense the serum calcium and maintaining the serum calcium level. So osteocytes, one hand osteoblastic activity, another hand osteoclastic activity. So they are doing by one pathway I told, rankel pathway. Another very important pathway is your sclerostin pathway. The sclerostin pathway is basically the newer targets for the osteoporotic management. So what happens? This sclerostin is basically stimulated by the osteocytes, sorry, and they prevents the osteoblastic activity. So sclerostin, what they do? Osteoblastic activity is prevented by the sclerostin. Whereas sclerostin causes more rankel formation so that osteoclastic activity is increased. Understood what is sclerostin? Sclerostin is secreted naturally by the osteocytes. So they are having the two important function. One function is they prevent osteoblastic activity, and second function is they produces more rankel. More rankel means what? More osteoclastic activity. So more osteoclastic activity means there will be bone resorption. So sclerostin causes osteoporosis. So prevents the osteoblastic activity, enhances the osteoclastic activity. So basically, sclerostin causes osteoporosis. Now, who stimulates sclerostin and who inhibits? So sclerostin is basically stimulated by, you see, these are the unloading. I'll be coming to this point later on. If somebody is not doing any physical exercise, very much relaxed, muscles are not pulling the bone periosteum. So if there is no mechanical pressure, on the on the periosteum, no mechanical stimulation. If there is some, these are some proteins. So bone morphological, some proteins are there. They also stimulates the the sclerostin, as well as the hypoxia, TNF alpha, interleukin 1b. So they all produces sclerostin, and sclerostin production means what? More osteoporosis. It prevents osteoblastic activity and increases osteoclastic activity. Whereas parathyroid, again, parathyroid has dual role, I told you. So what is the dual role? One role of the parathyroid, if the parathyroid is given intermittently, or parathyroid analogs like teriparatide, if it is given intermittently means once in a daily single dose of teriparatide. So what will happen? Teriparatide lasts in the body only for a few hours. And what will happen? Then osteoclastic activity will be there. So it basically inhibits sclerostin. So parathyroid, if it is given intermittently, or parathyroid analog like teriparatide, if it is given intermittently, then it's the inhibition of the sclerostin. Okay? Whereas if parathyroid is given continuously, like in a physiologically, what is happening? Our body continuously secretes the low doses of the parathyroid so that to maintain the our serum calcium level. Then what will happen? Opposite thing will be happening. That means they will be increasing the Rankel level. So Rankel level will be increased by the parathyroid if on earlier slide you have seen, if continuously. So this is very, this very having the dual action. Parathyroid physiologically, when our parathyroid gland is continuously secreting it, the basic function of the parathyroid is to maintain the body's calcium homeostasis, the level of the calcium, continuously at the same level. For that, the parathyroid is continuously secreting, and that causes the increased Rankel. And increased Rankel means more osteoclastic activity, so calcium will be released slowly inside the body, right? But if the parathyroid or parathyroid analog is given, for a short period of time, only for a few hours, then and only a burst, and then again there is no activities. That is physiologically not possible, but with the analog it is possible. Then what will happen? Then osteoblastic activity will be increased. Then that will be having the negative effect on the sclerostin. So parathyroid has both positive and the negative effect on the sclerostin. Parathyroid can enhance the Rankel, and parathyroid can also decrease the sclerostin level, and that is why it can be very effective. So two very important, the three very important molecules, I'll be coming to this later on, which is being used in the osteoporosis. One is denosumab. All of you know denosumab. Denosumab is what? Denosumab is the antibody against Rankel. That is your denosumab. But another very important monoclonal antibodies are available now in India. In fact, we have used in our hospital as well. That is the antibody against the sclerostin. Antibody against the sclerostin is your romosozumab. So if you are neutralizing sclerostin, what will happen? Then the negative effect on the osteoblast will be stopped, as well as the osteoclastic activity will be, the stopped, because the sclerostin is basically increasing the Rankel. So that Rankel increase is not possible. So newer target for the osteoporotic management is your sclerostin, the antibodies against sclerostin. One of them is romosozumab. Few other similar monoclonal antibodies are there, which is not available in India right now. Now, let us see what are the different hormones. Three important hormones are there, which is maintaining the serum calcium level. One of them is parathyroid. As you already mentioned, the parathyroid, if it is continuously released, then that causes the bone resorptions. More Rankel will be formed, and the calcium will be slowly released in the body. What is maintained? That is maintaining the calcium homeostasis. Whereas the calcitonin, that causes the bone, deposition, osteoblastic activity. But that osteoblastic activity is more pronounced in the younger, children and the adolescent, not in the adults. So calcitonin mobilizes the calcium to the bone only in the younger people, not in the adult. Parathyroid, I told you, physiologically parathyroid, they causes the bone resorption by increasing the activity of the rancle. Now, what is the role of vitamin D? To be very precise, it's not just vitamin D, it is the activated vitamin D. That means 125 dihydroxycholecalciferol. It has been hydroxylated at kidney and liver. Then it is active vitamin D, and it causes absorption of the calcium from the gut into the bone, into the blood. So that also increases the calcium level. And then parathyroid also acts on the kidney. Where it acts? It acts on the reabsorption of the calcium. So that is how also calcium level. So these are the ways to maintain the calcium level in the blood, because calcium is continuously being used for the different organs, the different areas. The calcium is being continuously used. So this who supplies the calcium? So calcium comes from here, from the gut, whatever you are taking. Calcium comes from here, from the kidney, reabsorption prevention, and calcium comes from the bone, parathyroid. So three important hormones are important, and calcitonin, obviously, particularly the young adults and the children's. In the adult, they causes prevention of the bone resorption, but they do not mobilize calcium to the bone in the adults or elderly people. So remember, there are the three important hormones. One is 125 dihydroxycholecalciferol, parathyroid hormone, and calcitonin, who is maintaining, and how it is maintaining, already told. One very important area is your the rank and rankle binding on the surface of the macrophage, which being activated to an active osteoclast. And here the rankle is very important to activate the osteoclastic activity. And another chemical what we have discussed is being stimulated, is secreted by the osteocyte, is your sclerostin. So this sclerostin prevents osteoclastic activity and increases osteoclastic activity by activation of the rankle. Right? So with this background, let us see what are the factors which increases the osteoblastic activity. So one is children or adolescent, where basically we tell that this is the time when you maintain your bank balance of calcium. In an adult, if you are giving lots of calcium, that calcium will be meeting your daily requirement, and then it will be excreted by the kidney and the stool. It will not being absorbed at all. And even if it is absorbed, it will be excreted. So giving lots of calcium in an adult is not going to correct your osteoporosis. This is very, very important, the concept. How do you have to remember? If you are giving calcium, that will might prevent the osteoclastic activity, well, because calcium is less needed by the blood because it is coming from the gut itself. But otherwise, in an adult, you cannot maintain your bank balance of calcium. So bank balance of the calcium in the bone, calcium is the bank. So that is the when to do in these children and the adolescent. The children and adolescent, adequate amount of the calcium to be given in their food. Bone remodeling, if there is a fracture healing and bone remodeling, then also there will be osteoblastic activities increased. Osteoblastic tumor, osteoblastic is increased. But very important is pressure on the bone, the pulling effect of the periosteum by exercise. Exercise is very, very important. As I already have mentioned, the sclerostin is being prevented if we are doing, you have seen here, the sclerostin, the mechanical stimulation of the bone. Periosteum, if it is pulled, then the sclerostin will be prevented, negative action. So the exercise is very, very important, that can increase your osteoclastic activity by suppression action of the sclerostin. Then teriparatide. Teriparatide is what? Some part, 1 to 35, 30, 34, your amino acid sequences are basically, it is the parathormone analog. It acts on the same parathyroid 1 receptor. And this is another, abaloparatide. Abaloparatide is not available yet in the India, but it has been used in the other countries. So their basic mechanism is same. They act on the parathyroid 1 receptor. And as I told you, here they are parathyroid analog. But if we are, there is a beautiful study I was going through today, that when the teriparatide is given once a day, then it will be causing the osteoblastic activity. But as I told, parathyroid, because it is being released continuously, it is causing osteoporosis, not the osteoblastic activity, osteoclastic activity. So can it happen with the teriparatide? Answer is yes. Suppose you are giving teriparatide by continuous infusion. Its half-life is around 3 to 4 hours. duration of action. So suppose if you are giving teriparatide, so this experiment was done once daily dose of teriparatide, twice daily dose of teriparatide, 4 times a day, and continuous. So you know what is very interesting, observation. So if you are giving once daily dose, then the osteoblastic activity is maximum. So there is increase of the the bone mass. If you are giving twice daily dose, one in the morning, one in the evening of teriparatide, what will happen? Then the osteoblastic activity is still there because its action is 3 hours, 3 to 4 hours, but its osteoblastic activity is less. If you are giving 4 or 5 times, then osteoclastic activity acts. And if you are giving continuous infusion, like physiological release of the parathormone, then there will be entirely osteoclastic activity that will be promoting the Rankel activity, and that will cause the more active osteoclast for the bone resorption. You understand? So funny how it is dual mechanism. Intermittently, if you are giving only for a window for a few hours, then that will be stimulating the osteoblastic activity. But continuous, either parathyroid or by this sympathetic, the synthetic or analog, then that will be causing the osteoclastic activity. So I was also, having this question, and I was, on the platform, I was asking this, that if we are giving parathyroid intermittently, so like teriparatide, will it cause osteoblastic activity? Answer is, what is happening, because our parathyroid hormone in our body is continuously released, as I was mentioning, because that has to maintain the serum calcium level. So there, if you are trying to use the parathyroid intermittently with a higher bolus dose, then that is not very effective. But because this teriparatide and abaloparatide, if you are giving it, that's action is only for 3-4 hours, because that same molecule is not available inside the body, because that is a synthetic. The parathyroid is already available in the body. So once you are giving the bolus dose, it will not be having that much effect, because then what will happen? Our body's own parathyroid hormone will be reduced. So ultimately, it will be maintaining the balance, continuous balance in the parathyroid. So that is being, the don't have the osteoblastic activity. But if you are giving teriparatide, because that is not going to suppress the parathyroid hormone inside the body, so that causes the osteoblastic activity. And romosozumab, how it acts, again I told you, that is another. Romosozumab basically acts dual mechanism. Teriparatide and abaloparatide only causes osteoblastic activity. But romosozumab, as I told, in our hospital also, for the last 1 year, we were using romosozumab. Romosozumab has dual action. It's like a denosumab. It causes the decreased activity of the what? Rankel, but not directly through the sclerostin, because romosozumab is a monoclonal antibody against sclerostin. So this sclerostin will be inactivated, and if the sclerostin is inactivated, sclerostin action was what? Sclerostin is secreted by the osteocytes, and it causes the prevention of the osteoblastic activity, increases the osteoclastic activity by increased Rankel formation. So that will be prevented by the romosozumab. So romosozumab has a dual action, and romosozumab is a very important, the weapon in our hand for treating the osteoporosis. Anabolic steroid is another which can increase the osteoblastic activity, but again, lots of side effects of the anabolic steroid. So, like durabolin, decadurabolin. Earlier it was used. Nowadays, these are not used in the osteoporosis management. Now, factors which increase the osteoclastic activity or bone decay. One is parathyroid, but again, here important is your continuous secretion. And here one things to remember, that the osteolytic bone lesion by the cancer cells, what happens? They work through the similar kind of parathyroid-like hormones are secreted by the cancer cell continuously. So that causes the osteoclastic activity, and the bone resorption is in that particular area. So osteolytic activity is basically by the parathyroid hormone. That is the reason why these drugs like denosumab, they can prevent the Rankel, and Rankel acts, parathyroid action by what? By Rankel, more Rankel formation. So that will be prevented. And so that means denosumab can be a very good drug for these osteolytic lesions as well. In Rankel, already I mentioned. So basically, many other drugs acts through the Rankel cycle. Lack of dietary vitamin D and calcium, because if we are not providing it the daily requirement, what will happen? The calcium will come from where? From the bone itself. So lack of dietary calcium, vitamin D, or gut restriction, or the calcium as absorption is not possible, or liver failure or kidney failure, because vitamin D is not basically the metabolically active vitamin D. So in all those situations, the osteoporosis is very common, like in the renal failure, like in the liver problem, liver failure. So the vitamin D is not getting activated. So in these situations also osteoporosis is quite common. But very important, what is in our hand is immobilization. Try to influence, try to mobilize, inspire your patient to walk or move the physical activities, exercises, because that is one of the very important in our hand, which how it will work? Already I mentioned, it acts through the sclerostin and other therapeutic agents like the glucocorticoid hormone or glucocorticoid hormone like activity like other drugs, which can cause the more rankle formations, more osteoclastic activity. Osteolytic tumors acts by the same way as a parathyroid hormone secreted by the cancer cells, right? So these are the activities or the other things which pathological conditions which causes the increased osteoclastic activity. Now, what are the factors which causes the decrease in the osteoclastic activity? One is osteoprotogerin, as you mentioned. How osteoprotogerin? Recapitulate. The osteoprotogerin binds with the rancle, like denosumab. Denosumab, how it works? Binds to the rancle. Same way, the osteoprotogerin is naturally inside our body. So osteoprotogerin binds to the rancle, and thereby it causes the activities. But osteoprotogerin therapeutically is not available. But the estrogen is basically same like that of the osteoprotogerin. In fact, estrogen has some positive effect on the osteoprotogerin so that it decreases the rancle activity. The calcitonin also causes the reduction of the osteoclastic activity by different mechanism. Exercise, very important. Denosumab by binding with the rancle, and bisphosphonates, they also reduces the osteoclastic activity by different mechanism. So this is the single table where we have mentioned all those things. So vitamin D, parathyroid, bone, all this maintaining these things. Now, this is again, I have emphasized this again, and this is by what? Sclerostin. If there is a less pull on the periosteum, what will happen? Then there will be more osteoclastic activity. So the bone mass will be reduced. And if you are putting strain on the bone, so that will cause the more bone matrix. And this is known as Wolff's law. So Wolff's law is what? That put pressure, pull on the periosteum. And that is one of the very important therapeutic option for us. By inducing the exercises, we can correct the osteoporosis. And this is how the loading and how the fracture can happen in the vertebral body. So now a very quick thing about most of us can remember these things, particularly we have covered this in the basic class, that the disc is being innervated by the sympathetic fibers, right? So, but remember, the sympathetic fibers also innervates by innervating the vertebral body. Sinovertebral nerves is innervating basically the disc, but basivertebral nerve is similar, which innervates the vertebral body. But the basic, ultimately, finally, they go through the sympathetic chains as well. And that is the reason why in vertebral compression fracture, if you are blocking the Raman communicates fiber, your pain might be reduced. Now, this is again very important. Dennis three-column concept of the spine. So, what are the three column? Anterior column is anterior two-thirds of the vertebral body. Middle column is middle two-thirds of the vertebral body. And posterior column is what? So, posterior longitudinal ligament is here. Anterior longitudinal ligament is here. So, this is posterior longitudinal ligament. So, anything posterior to the posterior longitudinal ligament is basically the posterior column. So, what is there in the anterior column? So, anterior longitudinal ligament, anterior two-thirds of the vertebral body, anterior two-thirds of the intervertebral disc. What is there in the medial column? Posterior under the vertebral body, posterior under the intervertebral disc, and posterior longitudinal ligament. And anything posterior to the posterior longitudinal ligament means whole of the spinal canal, the pedicles, the ligamentum flavum, facet joints. So, and the all the contents of the spinal canal, everything is there in the posterior column. So this concept, three-column concept, was first proposed by the Dennis, and it is being widely followed about this three-column concept. Now, these are the different classification of the fractures. This is just for overlooking. I'll be coming to this fracture classification, this one, modified Dennis classification. So here, the spine fracture has been classified into the 4 major class. One is, if the anterior column is fractured, anterior OS fracture, this is one, anterior OS fracture, basically this is the anterior column fracture. There is a middle column fracture. Middle column fracture is known as the Bast fracture. But again, remember, only middle column fracture is not possible unless there is some anterior column fracture or the posterior column fracture. And posterior column fracture, there are 2 types of posterior column fracture. One is flexion distraction. I'll be coming to the detail of that. Another is fracture dislocation. So this is anterior column fracture. That is your anterior OH fracture. Second is your middle column fracture. This is your Bast fracture. And these 2, flexion distraction and the fracture dislocation, these 2 are posterior column fracture. So these 4 types of fracture, out of them, the posterior column fracture has 2 types. So these are simplified or modified Dennis classification. So I'll be coming to one by one. So first is your anterior OH fracture. So there, the posterior middle column is intact. You see, the middle column is intact. Posterior cortex is intact. So only the anterior OH compression fracture is there. And here, the axial loading, most common thing is your osteoporosis. Without osteoporosis, the OH fracture is very rare, unless there is some, there is tumor, osteologic tumor is there in the anterior column. Then also this is possible. So if it is happening in the younger and the middle aged, sometimes it can be because of the accident, but younger, the middle aged, this fracture is less common. So these are the 2 types of, this is a fracture. But again, remember, the middle columns must be intact in this anterior OH fracture or anterior column fracture. And these are the ways how these different types of, initial pathology, how it starts. Then your thought we are going to manage an OH fracture. The OH fracture or anterior column fracture is best managed by the vertebroplasty. So we'll be talking about the vertebroplasty today, percutaneous vertebroplasty. So we can stabilize, and we can also, most important part is, the goal is to give the good pain relief with the vertebroplasty. So earlier this was done. 3 months conservative management. Now it is obsolete. Basically, if you are giving the bed rest, what will happen? Or the rigid orthosis. You are putting a very big orthosis cast so that the movement is not possible. So what we are basically doing, we are promoting more osteoporosis, because just now from the beginning we are trying to emphasize on this, how to prevent osteoclastic activity, how to promote osteoblastic activity, sclerostin, Rankel, all we have discussed, that these are all prevented by the exercises, traction on the periosteum, by the muscle pull on the periosteum, opposite. So if we are giving 3 months bed rest or 1 month bed rest in a spine fracture or OH fracture, what will happen? When the patient will start sitting, another level fracture, 2 level, 3 level, 4 level fractures is very common, because by forcing them to bed rest, basically we are aggravating the osteoporotic fractures further. So nowadays the concept has been changed. Nowadays, osteoporosis, try to do the management of the pain, try to mobilize the patient, and there, if needed, you do the vertebroplasty at the beginning. So vertebroplasty kypholasty is one very important. Earlier, the surgical fixation with a long cage was done. Nowadays, it is not done. Anterior OH fracture, the 1 level, 2 level, 3 level, 4 level you can do, if depending on whether those are the new fracture. Old fracture normally do not produces any pain. So our target is not the old fracture. But new fracture, even if it is a multiple level, you can do that. So surgical fixation is nowadays not needed for the anterior OH fractures. Rami communication block, I told you how it is effective, because ultimately the pain signal is going by the sympathetic fibers, by the Rami communicants and sympathetic trunk. So if you are blocking that, the Rami communicants, then also it will be effective. Epidurals also will be effective. Why? Because epidurals also causes the sympathetic blockade. Epidural which you are giving, it is not only blocking the somatic fibers, it also blocks the sympathetic fibers through which the pain is going. So that is also effective, but they are short-term effective. They don't give a long-term effect. But if vertebroplasty kypholasty is not possible and somebody is having a tremendous pain and we need to mobilize the patient, then we can think of the Rami communication block, or even simple epidural also going to help this patient, and we can make the patient quickly mobile. Remember always, vertebral compression fracture, particularly OS fracture, rest is not the treatment option, because rest is causing the more harm to the patient. So try to mobilize the patient with your analgesic protocol. If the pain is not maintained, relieved, then you have to go for any of this procedure to make the patient mobile as early as possible to move the patient. Then past fracture. Past fracture is what? It is a middle column fracture. And as I told you, middle column fracture alone is not possible. So either there will be anterior column fracture or there will be posterior column fracture. So when it is possible, it is normally the severe axial load. Again, these are more common in the the osteoporotic individual. Normally, the trauma history will be almost always anterior waist fracture. There might not be having any trauma. Severe osteoporosis, even the patient's body's load can cause the waist fracture. But the past fracture, it is normally not possible without any trauma. Even the slightest trauma is needed. And it can be divided into stable fracture, unstable fracture. When it is called stable fracture, if middle column fracture is associated with the anterior column fracture, then you call it a stable fracture. And if the middle column fracture is associated with the posterior column fracture, then you call it unstable. Because why? Always remember that the stability of the spine is maintained by the posterior column. Why? Because ligamentum flavum, interspinous ligament, supraspinous ligament, these are the structures which basically gives the stability. It prevents the gliding of the one vertebral body over the others along with the facet joints. So these are all posterior column structures. Facet joints is also a posterior column structure. Then the ligamentum flavum, the interspinous ligament, all these are very, very important to give the stability. So if the posterior column fracture is there, that means stability is lost. So we call it unstable fracture. The middle column fracture is associated with so middle plus posterior is your unstable blast fracture. Middle plus anterior is your stable blast fracture. So we can divide like this. Blast fracture, if it is associated with the anterior column fracture, means middle column fracture. If it is associated with the plus A, anterior, then you call it stable. If there is no neuro deficit, we can think of bartoplasty kyphoplasty as well. Though it is relative contraindication, it's not an absolute contraindication. With your expertise when you are seniors, you can think for the blast fracture. Even if it is a stable blast fracture with no neuro deficit, you can think of bartoplasty kyphoplasty, but with precaution. And if there is neuro deficits, even the stable fracture, the blast fracture, the neuro deficit is possible. If the posterior cortex, the not intact, that can impinge the spinal column structures and it can cause the deficits. In that situation, surgery is needed. If it is unstable, then definitely if deficit is there, then surgery is needed. If the deficit is not there, then it's controversial, but majority again prefers to go with the surgical intervention in the unstable fracture, even though there is no neuro deficits. Now come the posterior column fracture. As you mentioned, posterior column fracture are two types. One is flexion distraction and another is your fracture dislocation. Flexion distraction, fracture dislocation. You see, the fracture dislocation is also known as the seat belt kind of injury. So if there is the motor vehicle injury accident with the seat belt and sudden jerk, flexion, acute flexion, what will happen? This is the type of fracture. These are the different kinds of varieties of the fracture. How there is a distraction of the posterior column. This posterior column is actually pulled apart, and along with that, the flexion. Most commonly, it is known as the seat belt injury, and this is originally described as a chance. So it is also known as the chance fracture. So this is the posterior column fracture where there is a distraction type of fracture. And the other kind is your fracture along with the dislocation. So posterior column fracture, mostly, as it mentioned, the surgery is needed. So now, there is, when the surgery is needed or not, so there are different options. One of the very important way to understand, particularly this is important for the pain physicians, you can go through this thoracolumbar injury classification and the severity score, also known as TLICS scoring. So TLICS scoring this was the publications when it was suggested. So here, how do we do? We go through the injury morphology, ligamental structures integrity, and the patient neurology. So these three are very important. Injury morphology is by CT scan, MRI, both is needed, particularly the acute injury of the spine. We need both CT scan and the MRI. Bony fracture morphology is better understood by the CT scan, whereas ligamental structures and the neural structures are better understood by the MRI. And definitely, clinical evaluation is very, very important. So morphology by CT scan. So here the scoring is If it is a wedge fracture, anterior column fracture, then it is 1 point. If it is a middle column fracture, then it is 2 point. If it is a posterior column fracture, then it is a 3 point. Posterior column fracture means the transitional or the rotational injury. And if it is a distraction, flexion distraction, then it is 4 point. It is a morphology or CT scan. Then posterior ligamental structures. These are well understood by the MRI. If the posterior ligaments are intact, then 0 point. If the suspected injury or indeterminate or plus minus, then 2 point. If it is definitely injured, then it is 3 point. Then your neurological status. If the intact, then 0 point. If the nerve root injury, 2 point. Cord injury, if it is a complete, then 2 point. Cord injury, incomplete is 3 point. Why? Because incomplete cord injury where the immediate surgery has a very important role. So this scoring is for what? That whether the patient needs surgery or not. So incomplete cord injury needs surgical interventions immediately. And that is the reason why it is having the 3 point rather than complete injury which is having the 2 points. And cord syndrome also the 3 points. And what is the, what to do at the different score? If it is less than 4 point, then you treat it operatively, conservatively. Vertebroplasty, kyphoplasty can be considered in these situations as well. If it is 4, then again, it's basically plus minus. It can be treated conservatively or it can be treated by the operations. But again, final decision is by the clinicians. If it is more than 4, then definitive indication of the surgery is there. Immediate surgery should be done to, particularly if there is a, the neuro deficits are there. So, in summary, osteoporotic wedge fracture or compressive fracture is the commonest kind of fracture. So, bed rest and the immobilization should be abandoned as early as possible. Patient should be mobile with the management of the pain, and if needed, we can do the different kinds of intervention. Vertebroplasty, kyphoplasty is a very important, immediate pain relief is possible. Otherwise, if it is not possible, even then simple epidural can be important. Operative management is needed in some kind of fracture, and TLICS scoring can be very helpful to decide whether the surgical intervention is needed or not. So thank you very much. If you're having any question, you can ask me. After that, a little more detail about the osteoporotic management, diagnosis and the management will be by Shruti. Any questions?
Good evening, sir.
Yes.
Sir, is vertebroplasty or kyphoplasty, it is the same or different thing?
Okay, that will be decided, discussed by the, later on by Milton. Kyphoplasty basically
Okay,
we are inflating a balloon there. It's similar but not the same. Vertebroplasty, we are just putting the needle there and we are injecting bone cement there. And kyphoplasty is what? We are creating a space there by inflating a balloon, and then we are injecting.
Okay.
Advantage is what? That the leakage, cement leakage chance is much less. Okay, so they are not same procedure.
Okay, sir.
They are different procedure.
Okay.
Similar but different.
Thank you, sir.
But that will be discussed after the third lecture will be a Milton on the vertebroplasty and little bit on the kyphoplasty as well. Anything else? Okay, so Shruti.
Yes, sir.
Okay, so you can upload your slide and you can go ahead.
Okay, sir.
Somebody is asking about whether the 2 cm is needed. 1 cm is enough for vertebroplasty, kyphoplasty, but again, there is some O arm is there, sometimes 2 cm for the 2 angle, so that you can see in the 2 different angle about that when you are injecting the cement. But the most of the times we can do it the procedure with a 1 cm.
Sir, my slides are visible?
Yes, your
Yes.
slides are visible and you are nicely audible.
Okay, sir. Thank you so much, sir. Good evening, everyone. Today, I will be discussing about the clinical features and management of osteoporosis. As most of the anatomy and management, these are very nicely covered by sir. I will be briefing about this all. I will start with the definition of osteoporosis. So, according to World Health Organization, it is defined as a generalized bone disease, and it is characterized by decreased bone mass and deterioration of bone microarchitecture that you have seen in the previous slides. And it is not just about the losing the bone quantity, it's about just losing the quality of the bone. What comes under the quality of bone? That like architecture, the internal scaffolding of the bone, and that gradually starts to weaken. Later in 2001, the National Institute of Health, again, they redefined the definition, and they described osteoporosis as a disease of compromised bone strength that leads to an increased risk of fracture. So it reminds us that bone density alone doesn't tell the whole story. Bone strength is determined by both bone density and the quality. So, osteoporosis is not merely a disease, it is also a major risk factor for the fracture. Osteoporosis is one of the silent disease, and that is the most dangerous thing. Now, as we have understood the definition, so how to assess the osteoporosis? What are the tools we have to assess the osteoporosis, or to quantify, or you can say the how to know the quality of the bone? So we know bone dense strength is combination of bone mass and bone quality. Here, bone mass refer to the quantity of bone, how dense it is. So while bone quality refers to microarchitecture, turnover, and mineralization, unfortunately, at present, we do not have any direct or fully accurate way to measure either bone strength or bone quality in a living human being. So we rely on bone mass, which we measure as bone mineral density, or BMD, as a practical surrogate. So BMD, it accounts for 70% of the bone strength, and which means it's informative but not the full picture. So WHO defined osteoporosis based on BMD values, specifically a T-score more than 2.5 standard deviations below the mean peak of BMD of healthy young adults of the same sex. So when we say a patient's T-score is 2.6, that diagnostics of osteoporosis, and the term osteopenia applied to scores between -1 and -2.5. However, it is important to note that osteopenia is not a disease. There is no strong evidence that a T-score of -1 necessarily predict the future fracture osteoporosis. Yet, in clinical practice, many fracture patients, especially those elderly females, they fall into the osteopenic range. So, osteopenia, while not a disease, it often represents as a warning zone, and a stage where prevention and lifestyle modification can make a huge difference in future. So disadvantages of what are the disadvantages of T-score? First of all, the measurement itself based on a dual energy X-ray absorptiometry. You must have heard DEXA scan that gives us a two-dimensional projection of the bone density. So the result is always expressed in gram per centimeter square, but true density should ideally be measured per cubic centimeter. So this is a 2D measurement. So we are not capturing the bone volume here, only the area based estimate. So secondly, DEXA measures bone quantity, not quality. It doesn't access the microarchitecture, collagen matrix, or any mineralizations. So all of which are vital for real bone strength. And here thirdly, many patients with T-score better than -2.5 still suffer fragility fractures. So this happens. Why this is happening? Because BMD alone has a very low sensitivity, and the relationship between BMD and fracture risk, if you will calculate, It is continuous, not threshold based. For example, in other words, if you want to say, then there is no sharp biological cutoff where bone suddenly becomes fragile. And finally, it's worth remembering that T-score threshold were originally designed for research purpose to define inclusion criteria in certain clinical trial, for example. And this cutoff of -1 and -2.5 is also arbitrary, not an absolute value. So it should be remain as a screening, useful tool for screening. And we have to interpret considering the age, the risk factor, the fall tendency, and overall bone health. Then what are the pitfalls? What are the interpretation of the T-score again? Now let us interpret in real life. It is important to remember that T-score itself is independent of age, and it's purely a comparison to young healthy adult, but the meaning of the score changes with age. For a start, an elderly woman with T-score -2.5 carries a much higher fracture risk than a recently postmenopausal woman with the same score. Why? Because older females have often additional factors like poor balance, slow reflex, thin cortical bone, and high fall risk, all compound the fracture vulnerability. And secondly, while we interpret T-score, it is not also intuitive. Like a drop of 1 T-score unit represents a doubling of the fracture risk. So women of T-score -3 has roughly twice the fracture risk with someone -2, and nearly 4 times the risk with someone -1. But this gives us a relative risk. And we must not forget that fractures are not caused by low BMD alone. Falls, their number, their direction, their impact, all are equally responsible. So a perfectly healthy bone fracture can be a severe fall, while fragile one may never fracture if protected from falls. Again, there are various categories of the osteoporosis. First of all, we will understand that osteoporosis in postmenopausal females. So particularly in postmenopausal women, what happens? In normal cases, estrogen plays a central role in maintaining the healthy bone remodeling. It keeps a delicate balance between the bone formation by osteoblasts and bone resorption by osteoclasts. And when estrogen level falls, as in menopause, this balance is disrupted, and the deficiency shortens the lifespan of the osteoblasts and osteocytes, which are the cells responsible for formation and maintenance of the bone. At the same time, it increases production of the pro-inflammatory cytokines like interleukin 1, 6, and TNF alpha, which stimulate the formation and survival of the osteoclast, that the bone reserving cells. And there is an important molecular shift of the Rankel and OPG pathway that sir has explained nicely. The Rankel is now upregulated, that promote the osteoclast activity, and osteoproteaserin, this is the natural inhibitor of the Rankel, and that is downregulated. And as bone resorption exceeds the formation, we see a deeper trabecular erosion, and the internal scaffold of bone becomes thinner, weaker, and structurally compromised. Moreover, due to increased osteocyte apoptosis, micro damage accumulates, and here the bone's ability to detect and repair the micro damage declines. That leads to increased fragility. So here estrogen deficiency sets up a chain of reactions like cellular, molecular, and structural that will progressively weaken the bone and make it more prone to fracture. Then coming to the secondary osteoporosis, and not all the osteoporosis is primary or postmenopausal. We should think of secondary causes like which refers to bone loss, low BMD, and there is an increased fracture risk due to underlying disease or maybe sometimes due to medications. And before labeling the patient as having idiopathic osteoporosis, we should rule out all the secondary causes. Like certain tests we should do, like serum calcium, serum phosphate, and albumin. If there is an elevated calcium level, it may suggest a malignancy or primary hyperparathyroidism. On the other hand, if there is a low serum calcium, it can point towards a secondary hyperparathyroidism, maybe due to vitamin D deficiency or any renal disease, CKD. Next, alkaline phosphatase. If you find a high alkaline phosphatase level, it may indicate a Paget's disease of bone or certain kind of malignancy or certain severe osteomalacia. And if you increase phosphate, that is called reduced phosphate, that is the hypophosphatasia, though it is very rare and it presents with low alkaline phosphate, this is also another contraindication to anti-resorptive bones like bisphosphonates. So that's why it is important to do all the tests before starting a treatment or before ruling out the diagnosis. So we should also assess the thyroid function, especially TSH, because hyperthyroidism, even when asymptomatic, they can accelerate the bone turnover and causes significant bone loss. And finally, if you measure vitamin D level, it is essential to detect the vitamin D deficiency also. It is another common correctable contribution for secondary osteoporosis. Then screening, how to do the screening? Let us evaluate it with another few investigations like full blood count and ESR. These are simple, but it helps to detect any underlying inflammatory or malignant condition. If there is an unexplained anemia, also we should perform a serum protein electrophoresis or immunoelectrophoresis to rule out multiple myeloma. It is a classic cause of secondary osteoporosis. Next, always check the kidney functions, because renal impairment not only contributes to secondary bone loss, but also it influences the choice of anti-osteoporotic drugs, particularly bisphosphonate and denosumab. Parathyroid level is equally important. And here also, if serum parathyroid level, it helps to differentiate the so primary and secondary hyperparathyroidism, both of which can cause bone fragility. In younger male with low bone density, we also look for hypogonadism by measuring the testosterone level. And patients with unexplained malabsorption or low BMI, we should screen for celiac disease, including the TTG antigliadin antibody that will be elevated. And of course, when vertebral fracture are clinically suspected, for example, suppose a patient is having sudden loss of height or sudden back pain, spinal X-ray is the first step. Then if there is suspicion of bone metastasis, then you go for an MRI, X-ray or bone scintigraphy. These are the preferred imaging modalities. Then coming to glucocorticoid-induced osteoporosis. This is the most common form of iatrogenic osteoporosis, yet it is frequently overlooked by many physicians, especially in our case, and approximately 1 in 200 people will be exposed to glucocorticoid for at least 3 months. And among long-term users, up to 30% will suffer fracture, many of them vertebral and silent. Critically, the greatest bone loss occurs in first year of their starting treatment, and even low doses as little as 2.5 to 5 milligram of prednisolone daily are enough to significantly increase the fracture risk. And the risk is dose and duration dependent, but importantly, no dose is entirely safe when used chronically. And especially when we prescribe glucocorticoid for pain and inflammation, we should assess the fracture risk early, ideally when we start glucocorticoid. And along with this, we should provide calcium, vitamin D, and also consider anti-resorptive treatment for at-risk patients. So glucocorticoid-induced osteoporosis is preventable when we think it before the first fracture. Then osteoporosis in rheumatic disease. Conditions like rheumatoid arthritis, ankylosing spondylitis, SLE, and vasculitides like Wegener's granulomatosis or polyarteritis nodosa and Janssen arteritis, these all contribute to bone fragility fracture. Why? Because the disease combine multiple risk factors like chronic inflammation, which accelerate the bone resorption, immobility due to pain or disability, and of course glucocorticoid therapy. These are common in the management. Suppose let us take an example of SLE. Here, patients are often young females, yet still experience low bone mass and fracture. Why? Due to long-term steroid use, vitamin D deficiency, often from sun avoidance, amenorrhea, renal impairment, and reduced physical activity. And most important is bone loss is most rapid early in the disease course. likely driven by high disease activity and the use of high steroid at diagnosis. That means early screening is not optional, it is essential for this kind of patients. And we should identify those risks before they fracture or initiate anti-osteoporotic therapy when appropriate, whether that is calcium or vitamin D or bisphosphonate and any other agent, depending upon the patient's profile. In patients with rheumatic disease, osteoporosis is not a comorbidity, it is a consequence of both disease and also treatment. So we have to do early intervention in this kind of patients. Osteoporosis in men also not so uncommon. The lifetime risk of men over age of 50 is around 20%. So that means 1 in 5 men, and many of these fractures are preventable. And vertebral fracture risk increased from age 50 onwards, and hip fracture increased risk of after 65. Unlike females, where postmenopausal estrogen deficiency is the key driver, osteoporosis in men is mainly far more often due to secondary causes like glucocorticoid use, alcohol abuse, smoking, and in particular androgen deprivation therapy in CA prostate patients. A majority of unaddressed but cause is due to accelerated bone loss. Up to 50% male osteoporosis are secondary if they are missed unless a fracture occurs. So this is another idiopathic osteoporosis which affect men under 70 without any cause and not always remain poorly understood. That means we need to move the stereotype of osteoporosis as a women's disease. Men fracture happens also. So when they do, the mortality is higher than females. So these are very high risk cases. We have to evaluate accordingly. Then how osteoporotic fracture is likely? We often associate, if we are thinking of any osteoporosis fracture, 3 most common sites are there. One is hip, next is vertebra, and third is wrist. And rightly so, as these are the classic fracture sites for osteoporosis. And also it is important to understand osteoporosis affect the entire skeleton. Low bone density increases the risk of almost all type of fractures, not just these typical sites. So what is even more concerning is that a single fracture significantly raises the risk of future fractures. After a non-vertebral fracture, the risk of another non-vertebral fracture is almost doubled. And after a vertebral fracture, the risk of another vertebral fracture almost 4 times. And the risk of non-vertebral fracture is doubled. So fracture doesn't happen in isolation. They predict the recurrence of future fracture also. And while hip fracture get much of the attention, it's actually vertebral fracture that is more frequent and often go unrecognized. We also need to consider the challenges like obesity, diabetes. These are also independent risk factor for fragility fracture, even in absence of low BMD. Coming to the hip fracture, among all osteoporotic fractures, hip fracture is the most devastating. It will reduce the quality of life, it will reduce the mobility. In females, 20 to 30% of the females dies within a year of hip fracture, and 20% are left with severe disability that require long-term nursing care, and 50% never regain their previous level of mobility. This is not just a fracture, it is a like life-altering event. Hip fracture are typically due to multiple risk factor like low bone BMD and poor bone quality, high fall risk, other comorbidities with advanced age. And here hip fracture rarely just about the hip, it's a prediction of the future fracture also. So early intervention is mandatory here also. Then coming to the vertebral fracture, these are actually the hallmark of the disease osteoporosis. And unlike hip fracture, a vertebral fracture is not simply binary. It's not just fractured or not fractured. Instead, vertebral fracture occur as a spectrum and can be graded by severity. Like we in the previous slides, sir has shown that like mild 20 to 25% height loss, moderate 25 to 40%, severe more than 40% collapse of the vertebral body. And this can affect the anterior or middle height of the vertebra and typically assessed by comparing the deformed vertebra to the posterior height or to the adjacent vertebra if those are unaffected. And this grading is based on visual estimation and especially when evaluating the fracture risk or planning treatment. And many vertebral fracture go unrecognized. They may not cause the acute pain but still strong predictor of future fracture for both vertebral and non-vertebral fractures. So in osteoporosis assessment, we should look beyond BMD. So always assess the vertebral side also. And then this is a side, like we can say it is a silent epidemic. In only about 40% of vertebral fractures are related to falls, and most happening during routine activities like lifting a bag or patient is bending forward or even climbing stairs. Now, unlike hip fracture, vertebral fracture are often silent. And while some causes acute back pain, other presents with mild or no symptom. So as a result, what will happen? We are frequently overlooking the symptom, and we estimate that only 1/3 of the vertebral fracture are clinically recognized at the time they occur. A classic clue. What is the clue? You will notice loss of height, which should always raise suspicion in older adults. And another pitfall, even when imaging is done, vertebral fractures are often missed or misinterpreted. They must be differentiated from other conditions like Skewerman's disease, osteoarthritic remodeling, or a normal anatomical variation. Importantly, if a patient present with a vertebral fracture, and it will show neurological symptoms also, and this is not typical osteoporosis, must be prompt a thorough workup for malignancy and other pathology also. So vertebral fracture in patients without osteoporotic T-scores. So among postmenopausal women referred to bone mineral density testing, those with osteoporosis risk fracture but T-score more than -2.5, a surprising numbers are found to have prevalent vertebral fracture. That means even when BMD doesn't meet the threshold, for osteoporosis, fracture may already present, and we risk missing them entirely if we rely on T-score alone. So this proportion is even higher in elderly women that presenting with a recent non-vertebral fracture. For example, they have an hip fracture. So in these cases, vertebral imaging is not optional. Here it is essential. So vertebral fracture assessment is a densitometry technique like with the same time as a DEXA scan. It is a very quick, convenient, and critically it involves far less radiation exposure than standard X-ray. And in contrast, here cone beam X-ray, which results in parallax distortion, particularly vertebra above and below the beam central point, making interpretation more difficult. Coming to the non-hip vertebral fracture, while hip and vertebral fracture are very common, we should remember the non-vertebral fracture. These are actually most frequent osteoporotic fracture, and that include wrist fracture, proximal humerus fracture, pelvis, and proximal tibia, each carrying a significantly increased risk of subsequent fracture. Unfortunately, this fracture often underappreciated or neglected by us. So wrist fracture in particular have a unique pattern. How they have so they show a steep rise in incidence early after menopause. Then this contrasts with hip fracture, which become more common in older women. They show a steep rise in incidence after menopause, but they plateau later in the life. And in older women, as compared to the hip fracture, which become more common in older women, as a neuromuscular coordination deteriorates, making fall them onto the hip more likely than onto outstretched hands. Additionally, the fracture of proximal humerus, pelvis, and proximal tibia increase sharply with age, and their incidence is consistently higher in women than men. So every fragility fracture, no matter the site, should be a red flag for osteoporosis. Then coming to management of the osteoporosis, here our primary goal is straightforward. We have to prevent the fragility fractures. So pharmacological intervention is justified only when the benefits of fracture reduction clearly outweigh the risk and the economic cost of the treatment. Here it is important to remember that non-pharmacological strategies, they are play a very crucial role, generally with a negligible cost with additional health benefit. For example, simple measures like encouraging smoking cessation, promoting adequate calcium and vitamin D intake, and fostering regular physical activity like exercise, they substantially reduce the fracture risk without any significant expense. Together, these approaches form a comprehensive strategy where medications is reserved for those who stand to benefit most, and lifestyle interventions support bone health across the population. Ultimately, what will happen? The effective care will be balanced both. We have to balance both evidence-based treatment and practical preventions. So non-pharmacological, coming to the non-pharmacological treatment intervention, it is useful for patient with osteoporosis. Suppose a patient with low BMD, we will aim to avoid the occurrence of the osteoporosis by physical activity. Immobilization and bed rest quickly lead to muscle weakness and bone loss. That's why immobility should be avoided whenever possible. Exercise is the integral component in the management, and that helps to increase the improve confidence, muscle strength, coordination that prevents fall. And then third is the prevention of the fall. Also, we have to take care. Then mechanical loading also induce new bone formation by preventing the expression of sclerostin, a negative regulator of bone formation produced by osteocytes. Then while the typical West protein, calcium and vitamin D intake, like we have discussed, typical Western diet is always protein rich. Very elderly individual often consume diets high carbohydrate but low in protein. So we have to correct that poor protein intake part, and we have to, and that is important because high protein diet, it can limit the age related decline in the growth hormone, insulin like growth factor 1 axis. That by it will improve the bone mineral density, muscle mass, and strength. Many clinical evidence has been shown that when you increase protein intake in patients recovering from recent hip fracture, they improve clinical outcome, and also there is an reduced hospital stay also. So key nutrient here, calcium, protein, and vitamin D, particularly relevant in elderly patients. And also those undergoing anti-resorptive treatment or anabolic agent, and patients also on glucocorticoids. It will be helpful. Interestingly, the calcium intake and BMD are relatively weak, but benefit from calcium supplement primarily seen in patients those who have inadequate dietary calcium. There are few debates are still going on that potential cardiovascular risk of calcium supplement, especially regarding myocardial infarction. But this is advisable to encourage the patient to meet their calcium needs through dietary sources, and to use the supplement only if dietary intake falls below 1 gram per day. Then coming to vitamin D deficiency is extremely common in elderly and strongly associated with poor skeletal health. So a large majority of elderly individual, many patients with inflammatory joint disease, and also some significant proportion of the adults are not taking vitamin D. Even if vitamin D is insufficient. Importantly, vitamin D deficiency severely limits the effectiveness of anti-resorptive osteoporosis therapy. And vitamin D supplement, if you administer weekly, monthly, or every 3 months, depending upon the regimen. And to optimize the absorption, it should be taken with a fat-rich meal, like milk or at the end of a meal. Given the high prevalence of deficiency and excellent safety profile of the vitamin D supplement in clinical dosage, it should be recommended without measuring the vitamin D level. And daily dose should be 1,000 to 1,200 international unit is safe and effective also. Then indications of treatment: when you start the pharmacological therapy, after a thorough clinical evaluation, treatment is recommended in patient with this criteria. So first, a hip fracture or a vertebral fracture, whether clinically apparent or detected morphometrically, a T-score of -2.5 or lower at the femoral neck, total hip or spine, measured by DEXA. A low bone mass defined as T-score between -1 to -2.5 at the femoral neck, total hip or spine by DEXA. These guidelines emphasizes the importance of combining fracture history and bone density measurements to identify the patient who will benefit most from the treatment. Then coming to the bisphosphonates, that include alendronate, risedronate, ibadronate, and zoledronic acid. These are the established first-line treatment for most patients with postmenopausal osteoporosis. These act by working by inhibiting the osteoclast activity and induced osteoclast apoptosis. They reduce by reducing the bone resorption that lead to increased BMD also and enhance bone strength. And it is important to know that the bisphosphonates have a poor absorption, less than 1%, may cause esophageal irritation or GI symptoms. And that's why it must be taken with plain water on empty stomach. And patients should, or after an overnight fast, patients should remain upright and avoid eating or drinking for at least 30 minutes after taking alendronate or risedronate and 60 minutes for ibadronate. And if we are using two IV bisphosphonates like ibadronate and zoledronic acid, postmenopausal osteoporosis treatment also. And long-term risk and side effect, what could be the side effect of bisphosphonate? Though these are highly effective, there are many concerns. One notable concern is occurrence of atypical femoral fracture, particularly in the subtrochanteric region, or you can say femoral shaft in the diaphysis region. These fractures are uncommon, but they warrant careful monitoring of the patient, those who are on prolonged bisphosphonate therapy. And ibadronate reduce the risk of non-vertebral fracture, but they do not significantly lower the risk of hip fracture alone. So, and also in zoledronic acid has demonstrated a reduction of vertebral fracture, non-vertebral fracture and hip fracture also. It offers a broader protection. But common side effect amongst all is first IV infusion of bisphosphonate. The patient may suffer a typical flu-like symptoms within 24 to 36 hours. And these are self-limiting, and it can be effectively managed by simple analgesics like paracetamol for 1 to 3 days. Another rare but severe adverse effect is your osteonecrosis of the jaw. It is mainly seen in cancer patients receiving high-dose IV bisphosphonate. This is manifested by difficulty eating, speaking, or oral pain, infection, and necrosis of the jawbone. While osteonecrosis of the is uncommon in osteoporosis patient, but we should be aware of this side effect. Then coming to the parathyroid family, intermittent administration of parathyroid hormone, they are usually daily administered under subcutaneous route, and that stimulate and increase both number and activity of osteoblast. This anabolic effect leads to increased bone mass and improvement in the microarchitecture of the bone and both cancellous and cortical bone, and which is crucial for overall skeletal health. And currently, parathyroid hormone is the only anabolic agent available for osteoporosis. For example, teriparatide, the intact recombinant parathyroid hormone. The common adverse effects are like nausea, limb pain, headache, and dizziness. In patients with normal calcium level, transient and mild increase in serum calcium may occur after injection. This typically results after discontinuation of the calcium supplement also. So parathyroid hormone therapy is often used combination with another hormone, that is the calcitonin nasal spray. That will enhance your clinical benefits also. Another group of drug is like SERM, selective estrogen receptor modulator. These are also these are non-steroidal compounds, and they bind to the estrogen receptor and act either agonist or antagonist depending upon your target tissue. Example, raloxifene, 60 milligram if we administer daily. That was the first SERM approved for prevention and treatment of postmenopausal osteoporosis. And raloxifene effectively reduces the risk of vertebral fracture, and but its protective effect doesn't extend to non-vertebral fracture. Since then, the newer third generation SERM came, like bajedoxifene and lasofoxifene, that have been developed and approved. They have shown reduced vertebral fracture and non-vertebral fracture also. And there is but side effect is there, like hot flushes. There is a heightened risk of venous thromboembolism and no significant reduction in non-vertebral fracture. And despite these limitations, it is beneficial in women with postmenopausal osteoporosis, and along with bone, and they may benefit with patients who have risk associated with hormone replacement therapy. Another drug is strontium ranelate. This is an unique agent it inhibits bone resorption and stimulate bone formation in vitro. So it may uncouple the bone remodeling process when used to treat osteoporosis. And its anti-fracture efficacy has been demonstrated in both vertebral and non-vertebral fracture, and it has making it more effective. And common adverse effect is like nausea, diarrhea, very mild and manageable, but there is an increased risk of venous thromboembolism also. But with proper monitoring, it doesn't happen usually, rare side effect. And coming to the denosumab, this is recently approved agent for osteoporosis, and it is a humanized monoclonal antibody that selectively bind and neutralizes the rank ligand, and which is a key mediator for osteoclast formation and activity. And standard dosing regimen, if you ask, then it will be 60 milligram administered subcutaneously every 6 months. This schedule has been shown to produce a significant increase in spine BMD, and averaging over 9% over 24 months. So denosumab rapidly reduces the bone resorption marker, and they decrease the serum cortisol level, and observed in as early as the 3 days post injection. But unlike bisphosphonate, it doesn't have a residual effect after discontinuation. So once you stop the therapy, the bone turnover again rebounds after above the baseline level, and most gains in BMD are lost within 12 months. So we should be aware of this potential adverse effect. This is like skin infections, especially cellulitis and erysipelas are common, and other dermatologic condition like eczema also happens sometimes, and it causes reduced serum calcium level or hypocalcemia. That's why it is critical to ensure the patient to receive adequate calcium and vitamin D supplementation during denosumab treatment. So if you have any question, you can ask. Thank you very much.
Okay, thank you, Shruti, for your nice presentation. So one or two questions can be taken directly. Otherwise, you can put your questions in the chat box. Some questions are there in the chat box also. Shruti, please look at this. And
Yes, sir.
you can answer these questions, anything in the chat box. Or any one or two questions can be asked directly. Okay, then Milton, you can go ahead with your presentation.
Very good evening, and thank you, sir. And welcome to our all advanced fellows. So today our class is regarding the spine, especially the osteoporosis, and how we can treat these things with medication. And when actually in old age, it causes the osteoporotic fracture in the vertebral column. So how can we treat either conservatively or especially the very minimal intervention is there, that is the vertebral augmentation, like the vertebroplasty or kyphoplasty, other things. So we can do ourselves, especially the pain physician, and it is very rewarding procedure because after doing this procedure, patient give relief fantastically. So without any delay, just I am starting my presentation. So today, so vertebroplasty, if we see that it start around 37 years back in 1987. Gilbert started first he introduced these things in cervical hemangioma. As a treatment of cervical hemangioma, just he doing the vertebroplasty at the cervical level. So after 10 years later, the one RCT is published in the American Journal, and after 6-7 years later, FDA approved these things for the novel intervention for the collapsed vertebra, and right now we are doing by ourselves, and patient give a very good benefit from us. So what is vertebroplasty? So if we see that this is a very minimal invasive procedure, actually where we give the bone cement is known as the polymethyl accretate is injected into the Okay. So it is a very minimal invasive procedure in which we give the bone cement, injected the polymethyl meth aggregate into the vertebral body to relieve the pain. So it is a very good procedure, especially the vertebral fracture. So if we see that what is the classification of the fracture type? So one is the grade 1, grade 2, and grade 3. So in grade 1, if it is losses like 20 to 25% of the normal vertebral column, so this is known as the grade 1 compression fracture. So if it is more than 25 but up to 40%, it is known as the grade 2 fracture. If it is more than 40%, so it is known as the very severe type of the fracture. So especially grade 1 and grade 2, we are doing vertebroplasty. Sometimes we can do also in the grade 3, that's mean the more than 40-50% losses. But definitely if you are skilled, you have a lot of exposure in a lot of work, so that you can do this severe type of compression fracture, you can do the vertebroplasty. Okay. So we can do these things through the pedicle, and sometimes we can go
Not audible, sir.
What is happening, Milton? Internet problem?
We can't hear you.
Can you hear me? Am I audible?
You're audible and your slide is visible, or why it is happening repeatedly? Internet
Yes,
problem?
sir. Due to internet problems, sir. I am changed my internet connection through my
Okay, okay.
mobile. Actually, Wi-Fi is disconnected repeatedly due to electrical.
Okay, okay, okay.
So osteoporosis mostly primary, secondary we can do, and also we can do it in the trauma, traffic access, some fractures, sympathetic we can also do the multiple myeloma is very common, and hemangioma and angioma. So here we can do the vertebroplasty. So these are the most common indication where actually we can do the vertebroplasty. So patient selection, sometimes patient have a 2-3 level compression fracture, but if you see evaluate that which is the recent fracture and which fracture vertebra actually causes the pain. Suppose lumbar 1, 2, even thoracic 12 or 11. So they multiple level fracture is there, but only 1 or 2 level actually created this pain. So you have to specify which level actually create this pain. Okay, so very recently I got one patient have a very severe type of osteoporotic fracture in the thoracic 11, and another is the lumbar 3. Lumbar 3 is little bit less if you compare with the compression height of the vertebral column, vertebral height. So actually, but most pain in the lumbar 3, very little bit pain in the thoracic 11, but most fracture if you compare with the height or severity, so mostly in the uh, thoracic 12, thoracic area. So it should be always just by you, either it is recent fracture, is it create the pain. So this is the main issue where you need to the vertebroplasty. So this pain should be very focal, very intense type of pain, very deep type of pain, local tenderness. If you give pressure over the spinous process, so it causes the severe type of pain if it is recent fracture. Okay, so always correspond things, and also you should exclude either this causes the radicular pain or not. If there is any kind of radicular pain, radiculopathy, so you should always uh, clarify these things. Either this compression fracture is created the pain, or this actually radicular pain actually causes the pain, main issues. So you should clear these things. Okay. So some contraindication also there. So where actually we cannot do, if patient have a already healed osteoporotic fracture, patient fracture is there, but that is asymptomatic and stable fracture. That actually I give the one example. Just I got this patient just few days back. So allergy to the polymethyl methacrylate. Sometimes there is the untreated coagulopathy or anticoagulant therapy. Patient taken the anticoagulant therapy. Sometimes the we can plan patient have a osteoporosis. It may fracture in future, so we can go for the vertebroplasty, but never ever. It is the absolute contraindication. So never ever go for the prophylactic treatment of the osteoporosis. Patient have suffering in the osteopenia or osteoporosis. Never ever do advanced any advanced procedure without any kind of fracture. Okay. If patient have a discitis, osteomyelitis, sepsis, epidural abscess there, sometimes there is a cervical, severe cardiopulmonary disease. So these are the most absolute contraindication. Sometimes there is the relative contraindication, like the significant compression of the spinal canal, because we know that if spinal canal is already compromised, so sometimes it may causes the secondary obstruction or secondary compression to this kind of spinal canal. So patient may the quadriplasia or sometimes the paraplegia. So you should keep mind. So either you should go for this, not it is the relative contraindication. So back pain, and if patient have a fracture for like more than 1 year, so it is also the relative contraindication. So vertebral body compression fracture, if it is more than 90%, so that time actually you should avoid these things. Sometimes the tumor extension we can do for the tumor, like the hemangioma or sometimes the multiple myeloma or angioma, but we can do this. But if it is communicate with the epidural space, or if it is the extension to the epidural spaces, if you go for the cement, when cement is liquid in nature, so that time it causes the migration to the spinal cord area and causes the compression. Okay. And if patient instable, to lie in the prone position. Why? Because we need at least half an hour to 40 minutes to complete this procedure. So up to this time, patient need to still and patient maintain the prone position. So if patient have a severe type of pain, so and patient cannot prone position, so it also the relative contraindication. So you have to decrease this pain by any medication or any injection. So after that, actually you can plan for the this procedure. So selection criteria. So best selection criteria for those are starting or beginner. So single level is the best, or you can plan for the second level, like the couple of level, 2 level. And focal pain, and it should be always correspond with the MRI. Where is the edema? If it is painful, then only you can plan for this. If fracture less than 2 months or recent fracture, that is also indicated. Fracture in limited activity, and no sclerosis or fracture, no sclerosis of the fracture vertebra. If there is sclerosis and you are doing the, you are pushing the cement, sometimes it causes the refracture. Okay, so already healed or already sclerosed, already sclerosed line is there. If you give the pressure, if you give the cement, it causes the secondary fracture. Okay, so always better to avoid these things. So another is those patient have not less like to response to the vertebroplasty. So if fracture is more than 1 year, and other causes is the back pain, like the patient have a disc problem, like the disc herniation, spinal canal stenosis, any kind of facet pain, or like the sacroiliitis disease. So so these, if a patient have this kind of problem, so always avoid this type of the procedures. Okay, so patient selection, so this is the final criteria. So patient have a fracture, if it is more than 4 weeks, like the 4 weeks to 6 weeks, patient not improve with the conservative treatment. And if you go for the MRI, patient have a subacute or acute compression is there, edema is there, active fracture is there, so you can plan for the vertebroplasty if it is correspond pain at the vertebral fracture level. This is the very important clue. So pre-procedure imaging, so you have to go for the X-ray. If patient have a previous X-ray, so always compare. Sometimes the very like very little compression fracture, not more than like 15 to 20% losses. Only the upper edge or upper plate is losses. So that also sometimes create the say severe type of pain. So always compare with the previous X-ray if patient have previously done. So, and another is the MRI, especially the T1, T2 and ST-MRI. So you can see the recent edema, recent like collection within the vertebral bone of it is the healing. So you can compare these things. So another is the very, very important things in MRI or CT scan or other areas. So that is the important things is the pedicle. So if pedicle is already fractured, especially the medial side, so it causes the cement leakage. So it give the compression to the exiting nerve root and also the traversing nerve root. So it causes the cord compression. So another is the posterior cortex of the vertebral body. If the posterior cortex of the vertebral body is already fractured or already there is a breeze, so it causes the cement leakage to the cord area, and it causes the cord compression, sometimes need the immediate decompression surgery. So this is very, very bad condition and bad experience if you are not very careful about your procedure, or sometimes if you are not so much careful before the procedure, like MRI reading or the CT scan or other things, you have to see these things very nicely. And another is the BMD. Why BMD is needed? You can see that either patient have suffering the osteoporosis like them or osteopenia or other things. Because if on fracture is due to the osteoporosis, if T score and Z score is so high, next fracture may be happened after 1 to 2 years later if patient not taking adequate amount of the vitamin D, calcium, and also preventive medicine like the denosumab teriparatide and other things. This is very important. BMD, and patient can plan how to actually go for my next time. Otherwise, patient may develop the second fracture. Okay. So these are the common instrument during the procedure where actually we need. So you can see. So this is the plastic bowl, and you can see this is the one hammer. Sometimes we need the hammer, but especially in the osteoporosis, actually we no need the hammer because hand feeling is very important. So only hammer needed in young patient, those actually have a road traffic accident or fall from the height. Patient have a very good like bone health. So sometimes we need to hammer to travel through the pedicle, but especially in the osteoporosis, never ever use the hammer. Okay. And this is the Jamshedi needle. You can see this is the cement pusher. You can see, and these are the other painting substance. And here you can see this is the cement, and we have taking the ice within this bowl, and within this area we actually mixing this polymethyl methacrylate. These two things. One is the liquid things, and another is the powder. When actually we mix these things within the plastic bowl with reducing our room temperature, so it gives the more time to hardening. So you have a more time to push your cement inside the bone, inside the vertebral body. So it gives the more time due to use of the some ice cube. Okay. So here you can see this is the Jamshedi needle. Here you can see this is the guide wire. This is the, sometimes we can need the drill bits, cement filler. So these are the things actually you need in your procedure. So a lot of actually cement in our market. So actually I use this striker for last 3 years. So it have a very good benefit, and with cost effective, and there is still not, there is no problem I have faced or encountered. So this is the striker bone cement. So this is the powder, and this is the liquid things. Okay. So actually how we actually mix this powder and other things. So this is the polymer powder is there, and there is the monomer liquid, and sometimes the radio effect agent we can add, or sometimes there is the already added in the powder area. So it's maybe the barium sulfate powder, sometimes the tungsten and sometimes we can add the antibiotic when actually we mixture, and we have making this paste type vertebral filling substance. So we can mix these things, we can add the some antibiotic like the tobramycin or vancomycin. So before when actually you terminate the injection, so usually we feel the anterior 2/3 and the posterior 1/3 or posterior 1/4 area actually never ever we feel with the cement. Okay, this is the very important things. And usually CM patient should be the prone position. So approach usually cervical, we go for the anterior approach. So that time actually need to the supine position, other than like the dorsal or lumbar, we can go for the transpedicular or the parapedicular. So that time actually we need to the prone position. So this is the cervical area. So we can go through with our with guard our the vessels. Especially we need to always guard our carotid jugular vessels, and we should go just in between these area. We have to go just inside the vertebral body, and we have to give the cement inside the vertebral body. So here we can see, and now this is the thoracic and lumbar area. Usually our choice is the transpedicular. Sometimes we can go for the parapedicular, Sometimes we can also use the lateral transpedicular, lateral anteropedicular also, but most common things is the transpedicular. Okay, so we can insert our needle unilateral, and sometimes we can insert our needle bilateral also. So here, this is actually the, you can see this is the just particular area here. This is just touching this area, just in between the, this is a thoracic area. Okay. And now, very, very important things, that is the pre-procedure counseling. So you have to explain this procedure to the patient. So how you should go and how it work and how much actually time to heal, and always take a informed written consent. Okay. And during the procedure, so here is very important things, that is the anesthesia. Those we are from the anesthesia background, but never ever go for the general anesthesia. You can go for the, sometimes you can go for sedation like the midazolam, or sometimes at the fentanyl. But better go for the local anesthesia. What actually I follow, when actually I plan for vertebroplasty, before insertion of the Jamshedi needle, I have introduced one spinocaine needle 22 gauge, just touching the pedicle, and I have given like 1 ml local anesthesia and the at the just pedicle level, and just I have given like 2-3 ml of 1% lignocaine through the track, where actually which route actually I have traveled with my Jamshedi needle, because we know that this is the 10 gauge, sometimes we can use the 13 gauge. So it is a wide bore needle. So it creates the pain. So I have given plenty of amount of lignocaine, and I have waited for the at least 2 minutes. And after that, actually, I introduce my Jamshedi needle. So here, one important things, when actually I take a lateral view of with the needle, 22 gauge needle, so I can see my needle trajectory is in the right way or not, because you know that I have touching the pedicle, I have to travel the pedicle, and I have to reach the fracture area. So this alignment is okay or not. So sometimes actually, when actually we introduce our Jamshedi needle, but after that, if it is redirect these things, so it is sometimes already, because there is a wide bore needle, so it already created some muscle injury. So better to use the 22 gauge needle, and given the plenty of amount of like lignocaine, and wait for the few minute, like 2-3 minutes, and after that actually you can introduce your Jamshedi needle. So I have never ever used any midazolam or fentanyl. Okay. So before procedure, always give the antibiotic 1 gram or sometimes 2 gram, and always monitoring. Especially you have to monitor the saturation, pulse, and always better to talk with the patient. Patient is okay or not, patient have any kind of the other pain, patient have any kind of problem. So always talk with the patient. Okay. Because if there is any kind of problem, so patient can just notify you immediately. So this is very important. So why actually I'm not giving the any kind of midazolam or the fentanyl to the patient, because if patient is drowsy or sleepy, so patient cannot give the information if patient are feeling any kind of new pain or any kind of other incidents. Okay. So here we need to make our pedicle oval. So how we can oval? Make our ipsilateral oblique, little bit oblique. So it is very nicely shown by our sir. When actually sir go for the demonstration, we can see demonstration part. So it look like the oval shape. Here you can see the oval shape. So our target is, so it make it in 4 quadrangle. Okay, so 4 area. So like this, 1, and 2. So always our area is the upper and outer quadrant. Okay. So upper and outer quadrant. Upper and outer quadrant. Okay. Why? So here is the very important question. Why upper and outer? So number one, why upper? If we target our lower part, so sometimes we can breach the lower portion of the pedicle. If we breach the lower portion of the pedicle, so it causes the cement leakage from the lower portion of the pedicle, and it causes the it touching the exiting nerve. So patient have a very severe type of problem at the exiting nerve root area. Number one, why we are in the lateral side, not in the middle side? Because we have to travel from lateral to medial. So if we touch the medial part, so we have to breach the medial portion of the pedicle. If you breach the medial portion of the pedicle, what happened? So cemental leakage from the medial portion, and it causes the cord compression. So basically, we are very reserved from the spinal cord and exiting nerve, traversing nerve. So far, our target is the superior and lateral portion of the pedicle. Hopefully, this is clear why actually you are touching in the superior and lateral portion of the pedicle. Okay. Now, so how you have to step by step actually you have to proceed. Okay. So when actually we have see that this is the oval shape pedicle, and our needle touch in the superior and lateral portion of the pedicle in AP view, then I have to go in the lateral view. So that time it touches the posterior part of the pedicle. So this is the pedicle area, only the posterior part it is touches. Okay. So little bit I have go inside the pedicle, and I have touching just imaginary line. I have touching the middle pedicular line, not cross the mid pedicle. This is the mid pedicle, not medial, mid pedicle. So that time I have already crossed the around 50% of the pedicle in the lateral view. So after that, when actually we touching the medial pedicular border, so that time already I have touching the posterior cortex of the vertebral body. That's mean I have already crossed the pedicle. So here actually never touches or never breathes the pedicle. Okay. So if it is you are touching in the medial pedicle, but you are still in the middle of the pedicle in lateral view. So you have to travel more. So that time what happened? You have to breeze the medial pedicular border area. So this is the very, very dangerous part. So never ever actually you do these things. Okay. So here we can see the one procedure. You can see this is, we have introduced the needle. So after that, we have already introduced our needle little bit more, and we have to give the cement, more cement, more cement. We have filling mostly the anterior 3/4 and posterior 1/4, always never have filling with the cement. So almost filling. So after that, we have take the AP, and we see that almost the full of the vertebral area is filled with the cement. Okay. So here we can see this is the so needle ending at the anterior 1/3 and posterior 2/3 junction. And here we can see the both needle, and after that we have introduced our cement. Okay. So here one technique is there. So how you can actually mixing. So this is actually the we have taking this liquid. So after that we have taken this powder. So we have little bit powder we have taken, and we have to try to mix it and make it like the paste. If it is more liquid, so sometimes the venous actually connection, this cement actually leaks from this area. If it is more hardened, you cannot push this cement through this Jamshidi needle. Okay, so it make as the paste like. So cement injection already I have give these things. That is the cement. Always give it the anterior 2/3. Never ever fill in the posterior 1/3. This is the very important things. So after give the cement, we have push our cement to, because a lot of cement actually inside the Jamshidi needle, so sometimes block these things. So we have to push these things, and we have to take repeatedly epilateral and epilateral. So you can see epilateral and other views. So here we can see how much actually filling. After that, actually we can see in the AP, and if it is satisfactory, then you can actually stop this thing. So here you can see multiple picture. So epidural leakage, almost 50 to 70% cases epidural leakage is happen, but if it is very little bit, so there is not the so much actually problem. It never ever created this so much problem. If it is more, so that time actually may create the problem. So it's depend on how consistency of the cement you have made. So it's depend on it. If it is more liquid, so chance of actually cement migration through the venous plexus, it is very common. So another is the cement hardening. So you can create a ball, because you need only the 2 to 3 ml, not more than 1, 2, or maximum 3 ml. So one cement you can harden in the outside of the body. So when actually it harden, so that time you can just justify it is hardened inside the body also, because inside the body there is the core temperature and it is around the 37°. So it created more hardening within the very faster. Okay, so approximately 10 to 15 days is enough to harden this this cement. So another very important portion actually, how this hardened cement actually decrease the pain. So one is the temperature. So when actually if you see there, so, like this liquid and the this powder, when actually we mix these things, there is create the some temperature even in the inside the ball of the this cement. It created around 80 to 90 degrees centigrade temperature. So this temperature actually this nociceptive nerve ending actually destroyed by this temperature. So another is the stabilization. When is fracture is there, so one part like a friction over the another, friction create the friction over the another part. So when actually temperature is raised, sorry, when is it is stable, it causes the hardening. So it like it makes like the hardening this fracture area. So it's never ever sleepy or never ever like friction. So it causes the it produce the less pain. So one is the temperature, so another is the stabilization of the fractured part. So main these two things actually causes the decrease the pain to the patient. Okay, so cement flow actually depend on, if no flow, that's mean there is the hardening of cement very thick. If it is the very liquid type, so it causes the it go fast to the vertebral body, and it also it may travel from vertebral body to lungs. It may goes to the epidural spaces. So a lot of actually hazard is there. So it's always look like the paste. So we know the how much consistency of the paste. So we have made this cement as like as the paste. So post-operative care, so we have to take care around 2 to 3 hours, and in this time, so vital monitoring system is very important. Neurological examination is very important, because if there is the cement migration, cement leakaging, so it sometimes causes the neurological problems. So if there is any kind of problem, so we should go for the immediately we have to take the next steps. So how can actually reduce these things? So during the discharge, actually we have to give some advice to the patient, like care of the osteoporosis. This is very important. A lot of option is there, so they give a very good lecture. So here you can learn these things. And 2 days complete rest is very important, and 7 days only the house care, no work, no travel, no exertion, and no exercise. So after 1 month, till 1 month, patient should actually avoid the journey. A very short distance patient can do, but a basic routine class patient can do. So after 1 month later, patient can start with the little bit stress exercise, yoga, and other things. But never ever the heavy exercise. So after 2 months later, so patient can go for the normal life. So another patient should give your number and always give the some clue. If patient have a temperature like more than 100 degree, if patient have the any kind of motor weakness like new onset of the backache or breathlessness or other things, always without any hesitation, patient should contact with you, because patient may develop the other problem or other things. So if any kind of symptoms have patient have suffering, so always notify to you. Okay, so what are the complication actually we see? So minor complication like the 5 to 10% is most common. So major complication is with a less than 1%, and minor major complications. So most of the complication actually very self-limiting. So it is the transient self-limiting. So steroid therapy we can advise to the patient for if like a patient have some nerve root related to some numbness or other things, so you can give this steroid for 5 to 7 days, so patient may reduce with these things. And another is the surgery very rarely need, but if patient have a very severe type of like compression and a lot of actually cement is leakage, so that time actually may need it. So others complication like the small cement, so it is very commonly leakage like the paravertebral soft tissue area or other things, and venous plexus and other embolism may happen. So another is the perineuritis may happen. So if perineuritis is there, so you can advise the according to the patient. So small lung embolism may happen, the bleeding, pneumothorax, pericular fracture may occur, infection may occur, and other major things. This is the very crucial for the patient, that is the leakage of the cement in the spinal space. So sometimes need the immediate surgery, sometimes you can treat it with the medications. Spinal cord direct lesions lead to the paraplegia, and large lung embolism with the acute respiratory failure also is very bad condition, and the death is also very important if you are not taking care to the patient, so it may happen. So always discuss with the patient party what may happen, but most of the time the major complaint less than 1% time may happen, and it's very rewarding procedure when actually you do these things. So here is some picture of complication. This is the some cement leakage, just it goes inside the spinal canal, so it causes the small compression to the thecal sac. So it's here is the cement comes to the upper and lower disc area, and here you can see the small hyperic shadow. You can see at the lung field area. In the CT scan also see here we can see there is the broken of the pedicle. So this is the major causes. Here you can see the pedicle is breeze and both sides cement is leakage. Okay, so here is also and the cement is leakage, and when actually we have withdrawn our Jamshidi needle, so better to filling up to the pedicular level. So after the pedicular level, never ever push your cement pusher or cement filler. If you push this thing, sometimes it causes the this type of track, cement track. Okay, when actually you withdraw your Jamshidi needle after doing the procedure. So If we see the efficacy, so in case of the osteoporotic fracture, near about the 75 to 90% patient have experienced very good type of patient relief in neoplasm. So around 59 to 86% patient have experienced very reduced type of pain. So another literature also, RCTs also give like improvement near about 84% and no change around the 9%. So take home message. So vertebroplasty is a safe as well as the effective treatment for the vertebral compression fracture and provide rapid pain relief and restore your vertebral stability, and considered when the conservative treatment is failed to alleviate the symptoms and potentially complications should be careful when the weighted against the benefit. So it is justified by yourself as a physician. So thank you for patient sharing. If there is any question regarding the vertebroplasty, I will try to
Okay,
answer.
so one or two quick questions. Otherwise, I'll be starting demonstration. Any quick questions? One or two questions for Milton or me? We are here. I'm audible, no?
Yes, sir.
Okay. Okay, so, Milton, you stay there. If there are some questions, we can
Yes, sir. Yes, sir.
respond to that question.
Sure,
And
sir.
meanwhile, let me share the this thing. So my screen is visible for the
Yes, sir.
demonstration.
Three camera we can see nicely.
Okay. So left hand side, you are having the CM image. The vertebroplasty is done under the very good quality CM, or even you can use the in the CTV and CTVS the camera that I also you can use, because that is a very high quality CM. So high quality CM is mandatory for doing this procedure. So what is important? What is the? I'll be telling you some of the basic, because it's an advanced course. I'm expecting all of you are doing the basic spine procedures. So the basic spine procedures. What are the primary step? First step is to have a true AP image. Here also you are trying to have a true AP image. True AP image means the distance between the two pedicles will be same of the spinous process. But the next step is what? Correction of the lordosis. So here correction of the lordosis is not important. In fact, we don't try to correct the lordosis. In fact, we should be keeping to increase the lordosis. Sometimes, we put one pillow there under the in the thigh and one in the chest so that the lordosis is increased. Why? Because then there will be opening up the vertebral body, so the fracture side will be opened up. So the bone cement injection will be more easy. And how much cranial tilt is needed or not needed? So all depends on, you see here, like my pedicle is, this is the vertebral body height. So if the fracture is there, the height, the anterior wedge fracture, the height is lost. So it is difficult to determine. But what is important here, the posterior cortex is most of the times will be intact, and your pedicle should be in the middle. So in this level, I don't need a craniocaudal tilt. But sometimes at this level, I need a craniocaudal tilt. So how much craniocaudal tilt? So that the pedicle comes in the middle of the vertebral body. That is what is craniocaudal tilt is needed. So we are not looking for the end plate parallel. That's what we do in the other lumbosacral procedure, right? So the first step is true AP image. Next step is make a craniocaudal tilt, not to make the end plate parallel. Squaring is not needed here, but what is needed? Craniocaudal tilt is needed for the pedicle to bring in the center of the vertebral body. In the height of the vertebral body, it should be in the center. And then what you do? I am describing here the transpedicular. Extrapedicular can be done in the thoracic area, particularly the upper thoracic. Lumbosacral areas normally, or the lower thoracic areas normally you do the transpedicular. Transpedicular is more safe because if the leakage is there, it will be coming through the pedicle itself. So for that, what we need to do? We can do in the AP view. There are two ways to do. We can do in the AP view, and what we can do, we can start in this area, I mean upper and outer quadrant. Why? Because you imagine the nerve root is coming here, exiting nerve root is one is coming here, one is coming here. If your needle is here, lower part of the pedicle, that means you are closer to the exiting nerve root. So it is more dangerous. So that is the reason why that our needle should not be here. Our needle or the vertebroplasty needle should be in the upper and outer part, basically where we do the eye of the Scottish dog. So that should be the areas. You can start with the AP view, or you can do a oblique view till you can see the pedicle best. Seeing the pedicle is important. And once you see the pedicle best, you start always again the upper and the outer part. And I explained to you why upper and outer part. And then you go in the middle of the pedicle if you are doing oblique view. But if you are starting in the AP view, always start in the this position, eye of the Scottish dog, that area, and you then go ahead with the needle. So what I'll be doing here, I'll be making a oblique when the pedicle is best seen. Pedicle is best seen means in the AP view, the pedicle is seen, but when you are doing the oblique view, normally this length of the pedicle will be increasing. So when the pedicle is best seen, that is the area time, and the upper and the outer part, the needle should be introduced. I am introducing the ordinary needle, ordinary spinal needle, because otherwise that will be damaging it. And already there is some, some drill is there, so that in a normal pedicle, it is difficult. You need to do the hammering, and in the osteoporotic, you have to fracture there, you have to push it. But here we are not doing that because that will be damaging the mannequin here. But what is the purpose of this thing is how to introduce the needle, and what is the lateral view, how much of lateral view is needed. That is what is the what I'm going to tell you. Okay, so there I'll be trying to introduce my needle. In the when you are making it oblique, it will be tunnel vision. But when you are not making it an oblique, in the doing in the AP view, then the tunnel vision is not needed. Okay, so now what I'll do, I'll be going by the AP view. What is important that, sorry, lateral view. In the lateral view, my needle should not be, till I am outside the posterior cortex. I am in the pedicle, right? So I have not still crossed the posterior cortex. So you see, now I am almost touching the posterior cortex. So when I am touching the posterior cortex, again, go in the AP view. In the AP view, my needle should not cross the medial border of the pedicle in the AP view. So when I'm in the lateral view, I'm still not crossing the posterior cortex. So what is important here, that my needle, you see, my needle has not crossed this is the posterior cortex. So that is the lateral boundary of the spinal canal. I must not cross this medial pedicular line until in the lateral view, my needle has crossed the posterior cortex. Once I have crossed the posterior cortex, means I have reached the vertebral body. That time your needle tip can be reaching there. So again, you see, I'm going into lateral view now. Again, always advance the needle in the lateral view. So epilateral, repeated epilateral is needed. Okay, Nishan. So what I'm doing, I'm pushing the needle more. Normally in osteoporosis, you just go with thumb, you can just push it. So now I have crossed the, the posterior cortex. Now you see the AP view. Now I can, if my needle is crossing the post medial border, you see, now my needle is touching the So you see, my needle is just crossing the medial pedicular body. So it is accepted because I am already in the vertebral body. Once you're in the vertebral body, that time your needle might be crossing the medial pedicular border, no harm. But till you have not entered the posterior cortex, your needle must be away from the medial border, medial pedicular line in AP image. Okay, lateral. So how much should I go? You should be going in the, if you're dividing vertebral body in the lateral view into 3 areas, your needle should be going the anterior third, or some say anterior fourth. So if you are dividing this vertebral body into the middle and anterior, so my needle should be coming here. Still little more picture. একটা সিএমটা নিচে নামা মাথার দিকে নেই আরেকটু নিচে নামা okay so my needle has come into the anterior almost closer to the so in the anterior 1/3 or the anterior 1/4 my needle should come and then I should start feeling the injection there. So you see my needle has crossed the medial pedicular border but that is not harm because I am already in the vertebral body. So again, go into the lateral view. When you start injecting the bone cement, you should be always starting the bone cement in the lateral view because the most dangerous part is your cement must not come in the posterior body. Posterior 1/3. So this part, the cement should not come. So you start feeling from there and gradually withdraw, and you can still feel the anterior and the middle part, but posterior 1/3 or 1/4 part must not be filled because here this is the posterior cortex, but that might not be the posterior border in the middle of the vertebral body because the vertebral body shape is like this. So what we are seeing here in the lateral view may not, it is the posterior border in this part, means lateral part, this part and this part. But the middle part is little bit of deeper inside. So middle part, the up to here might be coming. So if the cement is coming in this area, actually the cement might have come in the epidural space. So that is the reason why the cement should never come in the posterior 1/4 of this. That is the dangerous area. You should not be injecting cement there. So start filling from here and gradually withdraw the needle and come fill the middle part. So anterior third fill, middle third you fill, posterior third don't fill. And that is not needed also because we are doing it in the waist fracture. Waist fracture means posterior column, middle column is your intact, means posterior middle 1/3 or the posterior 1/3 of the vertebral body is intact. So vertebral the cement injection is not needed there. Okay, so this is how the vertebral is done. Any questions if you are having, you can ask me.
Sir,
Yes.
so we should not remove the needle until it gets hardened outside.
Yes. You have to
Body?
have the cement outside the body, and you see till the cement has completely hardened. Till then, you keep the needle there intact, and then withdraw the needle only when you see it is very solid, and that time only you remove the needle.
Yes, sir. Thank you, sir.
Sir,
Yes.
sir, yes. So what did you do in the obliques, making the siam in the oblique side?
Oblique side is to see the pedicle nicely. You may not do the oblique. You can
Okay.
start with the AP view itself. Both are acceptable.
So basically we are doing on the AP and the lateral view.
AP and lateral always, but when you are starting, that time if you are making
Yeah.
it oblique, then the pedicle is much
the
more
lateral.
focused and better seen. That is the reason why because it's a
So
vertebral compression fracture, it is very osteoporotic. Many times you will not be able to appreciate the pedicle nicely in an AP view. So to make the pedicle
Okay.
better seen, you can make a little bit of oblique till the pedicle is best seen, and then you can start, and then epilateral. Then oblique view. Once you have started your needle entry into the vertebral into the pedicle, then no need of doing any oblique again. Oblique is needed to identify the pedicle nicely.
So basically first on the AP view we need to identify the pedicle and then go for the oblique view to identify the pedicle again on the linear portion and
Yes,
then
and
AP lateral,
even if
AP
you are
lateral.
not able to identify the
And then
pedicle
basically
nicely,
start with the lateral.
right? Epilateral is you have to do. Oblique is just to identify the pedicle better.
Okay. Thank you, sir.
Yes.
What is the percentage or chance to injure the medial nerve here, sir? In
If
this
it is injured,
outer and
that possibility is there.
upper.
Median nerve injury is not causing it. In fact, that causes no harm, good. Because what
Yes,
happens,
sir.
vertebral compression fracture,
It will give
the
pain
facet
relief.
joint is a very common associated problem. What is basically the second source of the pain in the osteoporotic compression fracture? Because facet joint is basically stressed.
Loading is increased.
So median branch block is not going to do any harm. In fact, medial branch, if it is damaged, injured, that is basically causing benefits to the patient.
Any differentiation pain after medial nerve damage?
Medial nerve, we are already doing it. So differentiation
Yes,
pain
sir,
with the
but
medial nerve.
okay. Thank you, sir.
Because cutaneous supply is not there, that is the reason why differentiation pain in the medial branch ablation is very rare.
Okay, okay, sir. Thank you.
Extremely rare. In fact, not reported. Okay, so this much today, and seeing you on the next Tuesday. Next Tuesday, somebody was telling that, okay, Diwali, but again, we'll be continuing with the classes. Those who will be, engaging in the Diwali, see the recorded lectures later on, but we'll be following our schedule. Okay, thank you very much, and good night for today.
Thank you, sir. Good night, sir.
Good night, sir.